Welcome back to the Hand to Shoulder Solution, giving pain the middle finger. I'm Carl Petito. I'm an occupational therapist and a board-certified hand therapist. I specialize in the rehabilitation of orthopedic conditions that are affecting the fingertips through the shoulder. So any condition that's causing pain or stiffness or any problems from the shoulder on down, that's my specialty. I work closely with hand specialist surgeons, general orthopedists, physician assistants, nurse practitioners, my colleagues as other occupational therapists, physical therapists, to get you well in minimal time. What this is not treatment or advice. I would have to see each person individually to thoroughly examine their condition. So every condition inside of every patient can be very, very different and very unique and really change what tools in our toolbox that we use and how we use them. So this information is sharing so that you may be empowered to make decisions for yourself in accordance with your healthcare practitioner. So picking up where we left off on a previous episode about conditions of the wrist and hand, let's go a little bit more into the hand and fingers. And there's tendons there that are very shallow or superficial, close to the surface. They glide right underneath the skin, and people often cut their fingers. And when you cut your fingers or cut your hand, if you sever the tendons that connect the muscles to the bone, now you're not going to get movement. So one common injury is trying to separate frozen food with a knife. The knife slips and goes into the opposite hand, and you get a deep cut. And then you realize, when I close my finger or I close my hand and I make a fist, my one finger is not bending. That means you probably cut your tendon. And when you cut the tendon, now there's two wounds. There's a wound of the skin and the wound of the tendon. Now, let's start by talking about the tendons on the back of the hand, the extensors. So when you extend, you're straightening. When you flex, you're bending. So when you straighten or open your hand, that's your extensors. When you close your hand or bend your fingers, that's your flexors. One common thing is people get in a fist fight and get what's called a fight bite, where the knuckles get caught on the person's tooth and the tooth actually severs the tendon. When we're speaking to each other as professionals, we break up the tendons in zones, and we can say in zone 1 or zone 5 or zone 6, the tendon was ruptured. Surgeon had to do a repair, and that determines what I do regarding rehabilitation of the repair based on where it is located within the fingers or the hand. So let's talk about the big knuckle, okay? On the previous episode, we talked about the sagittal band that keeps the tendon centered on the back of the joint when the fist is bending. If the sagittal band is ripped, the tendon will roll out from its groove that it rides in, and it'll fall down into this trough. And then when you straighten the fingers or extend the fingers, it'll now roll back onto where it's supposed to be, and that snapping will occur. Now let's say that can happen just from arthritis, and then and that's usually the cause of that sagittal band rupture. That's why those usually rupture. But let's say fight bite or a knife slipped or any trauma that now it went so deep that it cut the tendon, and now this is happening. The finger will straighten because the tendon is severed. So the surgeon has to go inside and sew the tendon end to end. There's a lot of different surgical techniques. There's different ways that the surgeon can make loops with the permanent suture material. They even make knots on the inside of the tendon. It's really fascinating. They'll wear items. They're called loops. They're magnifying glasses, so they can work at a comfortable distance and really magnify that tendon and use really very, very fine suture material to sew that tendon end to end. Now, What's nice surgically is if that tendon is a nice clean laceration, it can be sewn end to end. It gets tougher when, let's say, a machine took out a patient slipped, and now let's say a wide saw blade or something cut the tendon. Now there's a chuck missing out of it. If the tendon is too short here, now you can't make a fist because now you don't have the flexibility. The tendon is not long enough. If the tendon is too long, now when you open up, the muscle only contracts so far. So if the tendon is too long, now you're not going to be able to raise your finger. So the surgeon has such a crucial job of making sure that length is perfect. Now, if there's a chunk missing out of the tendon, then a graft has to be done. They have to pull a tendon, or sometimes a slip of tendon, a slip of material. So if you were to take string cheese out of your refrigerator and peel off a piece of the string cheese lengthwise, that's taking a slip off of it. So you take a slip of tendon and do a graft, and now what I have to consider is now there's two wounds on the tendon, because now you put a length of tendon inside that area that's missing, and now there's two repairs. So there's a repair here, and there's a repair over here. Now, what I cannot allow to happen as a therapist is we can't get what's called an adhesion. So remember, at a minimum, there's two healing wounds. So you got the scar that's developing on the skin where the cut was, and you have a scar that's developing on the tendon repair underneath the skin. Scars like to mesh to each other. Scar tissue gets sticky is a good way to think about it. And if they mesh together, now the tendon is not gliding under the skin. So when the muscle contracts, there's not going to be any movement of the finger because it's stuck. It's literally stuck. Now, how do we prevent it from getting stuck? With specific movements so it doesn't have a chance to get stuck. That's the dichotomy. So now there's a dichotomy. There's, on one hand, or one for instance, we can't let it get stuck. It has to be moving, usually, 10 to 15 repetitions, 3 or 4 specific exercises every other hour, but not more. The rest period is just as important as the range of motion. So every 2 hours, the specific range of motion that I really thoroughly educate patients on. But at the same time, we have to protect it enough so that it doesn't, the rupture or the repair doesn't rip apart. And if it doesn't rip apart, we can't let it gap. Because now if you have a gap, and it can fill in, if you have a gap, now your tendon is too long. So now it's not going to raise up because it's too long. And remember, the muscle only contracts so much. So it really has to be perfect. And you have to, as a practitioner, I have to have my patient be really compliant and really follow instructions and pay good attention to detail. So patient education is one of the most important parts of patient care. So I explain all of this in great detail to the patients. My initial visit with patients is an hour. So I explain what's going on, explain what was done in surgery, if they had surgery, explain my recommendations and why am I recommending these things, and explain the home program, what they have to do every 2 hours. And then I also make a protective brace custom. So I make what's called a dorsal blocking orthosis or dorsal blocking splint. Now, that would be for flexor tendons. We're talking about extensor tendons. So what we want to do is these tendons back here, we want to keep them on slack a little bit. So I would usually make a brace, a little gutter here that keeps the hand up. So these tendons are on slack. But now what about the finger? Now we can do a little relative motion orthosis where now you have the wrist brace holding it up and now the finger is up too. But they can still use their hand and it's protected and it's allowed to heal. And then as they get healed further, and the healing continues, we can remove the wrist brace and only go with the finger brace. And then the last step is to remove the finger brace. And there's a lot of other, specialty treatments that also go on inside the clinic, ultrasound, Once the scar is developing better, more healing is occurring. We can start doing some light scar massage. Where some patients go wrong is, most of us are good, hardworking people. We assume that more is better. And with healing, more isn't better. So scar massage some people will be told, just keep massaging that, keep rubbing it, but that's going to increase inflammation. I have people use a little bit of lotion for lubrication once that scar is developing, and they would massage, literally just rub it, firm, not hard, not aggressive, for about 2 minutes, only about 2 minutes, probably about twice a day, and then leave it alone and continue with their exercises that they're supposed to do every 2 hours. Now let's talk briefly about scar. So scars mature or develop over a period of about 2 years. The first 8 months are most important. So if you look at your normal skin under the microscope, the fibers are nice and flat and parallel. As scar forms, the fibers become crisscross and lumpy. With deep pressure, we can get the fibers to reorient and become parallel again and flatten out. Also, you can think of scar tissue as brand new baby skin. So it's new to the world. The body just developed it. It's very typical for the scar tissue to be very sensitive, sensitive to the touch. That'll go away. That'll develop. It's easy to panic and start getting more aggressive and just trying to treat it. So the more aggressive that a person gets on it, the more sensitive it becomes, because now we're just irritating it more and more. Now, another tool we use, and there's so many tools in hand therapy, there's just, a lot of stuff. So this is a compressive finger sleeve. So I would usually, open one of these up. They make nice gel lined pads. But if I ran out of those or don't have them around, I would improvise and just open up one of these finger sleeves. And what I would do is take that gel and lay it right over the scar, and then maybe fold up a piece of material as a bolster, and have the patient wrap that onto his or her hand during sleeping hours. And that light compressive force over the scar wrapped around there, and with the gel pressing on the scar, will literally flatten out that scar and then make the scar more soft and supple. So that's a really nice technique. Having these tools, just improvise and educate the patient to what they need, and just fabricate whatever is needed for that spot. There's also a nice Part A and Part B material that you can put together like putty, and then it solidifies and still stays kind of rubbery. They can mold right over that, and then wrap it with light compression and wear that once or twice a day for a half hour, or also all night long when the patient is sleeping, to really flatten out the scar. And then over time, over the 12 to 24 months, the scar itself, the color starts to normalize and match the surrounding tissue. So it's not anything that we have to be really in a big hurry about, but scar tissue really has to be well managed with any tendon repair. So that's the extensor tendons. We want to keep those protected while they're healing, but at the same time prevent them from meshing together. Now let's talk about the flexors. So the flexors, flex the fingers or bend the fingers. I had a guy probably 15 years ago. He was putting on a metal roof and he slipped and he caught himself on an edge, and both of his hands slid down the edge of the metal roof, and it severed all of his tendons and his index, long finger, ring finger, and small fingers. On one hand, the other hand was a couple of fingers, and it was a pretty serious situation. In the fingers, there's two tendons because to each finger because there's two muscles. We talked about that on a previous episode. Laying against the bone is flexor digitorum profundus, and that tendon goes through the carpal tunnel, and it goes to the tip of the finger. So when you bend the tip of the finger, you're using flexor digitorum profundus. So if we take off a couple of these muscles in the forearm, and we get right down to these muscles here, I don't think this goes deep enough, but the red is a muscle, the white part's a tendon, and these the flexor digitorum superficialis, FDS, it goes down to the middle bone of the finger and it splits apart and it inserts like that. The profundus, the whole separate, another flexor muscle in the forearm, it goes between those two and inserts on the tip. So when you bend these big knuckles and these middle knuckles, you're using superficialis, which lives more superficial or more shallow, and then the profundus is underneath that, more deep. That's how we can have such a tight grip. So depending on where the laceration is, where you have a cut on your hand, that will determine what we do in therapy, and the surgeon will let me know, was both tendons to the muscles severed, or just one, or was also some nerves severed too. So the surgeon will do the nerve and tendon repairs and then communicate with me what exactly he or she had to do in surgery. And it's just fascinating what they can do in surgery and fix this stuff right there on the spot. And then same with the extensor tendons, like we talked about. We cannot allow the two scars to mesh with each other, the scar of the repaired tendon and the scar on the skin. Now, the patient has to do the exercises every 2 hours. Otherwise, you're going to get those mesh together. Now, what happens if they mesh together and the tendon gets stuck? The surgeon has to do what's called a tenolysis. That means another surgery for the patient. And I explain this all to the patient ahead of time. Hey, if you don't do what I ask you to do, or also if you do too much and the repair ruptures or gaps, or if you have a problem, it's going to mean another surgery. So for the flexors on the palmar surface, picture this, if we do this, it's going to tear out the repair, right? So we have to make what's called a dorsal blocking orthosis. So it goes over the back of the forearm. It keeps the wrist bent toward the palm a little bit so the tendons are on slack. And then the big knuckles are kept bent to about 45 or 50 degrees, and the small knuckles are kept straight. So everything is on slack here. There's no tension on it. And then they do exercises to the limits of the split. And they might do 20 of those, and there's some other more specific exercises that are designed to keep that tendon gliding underneath so it doesn't get stuck. Also, at the same time, it's being adequately protected. And then we wean them out of the brace, and then eventually start some ultrasound, some work on the scar, and then eventually get to the point where they're doing strengthening. And I want to remind the public that strengthening with a ball is not healthy for the hand. It's natural for us to think, well, let's just use a ball because the hand is kind of cupped. But the ball makes the hand more cupped, and it tightens these palmar arches, and it tightens the intrinsics, which we talked about on a previous episode, the intrinsics being intrinsic to the hand. So what's more healthy is something that can be adjusted better too, is something square like this. Or if you're at home and you just like to exercise, you don't have any injuries or anything, even something like this, but not a ball. Here's an old one. Same idea as this, but it has springs up to 6 that you can put on this thing. But this is advanced as the patient. Sometimes we'll just start with one really tiny little band just to give the tendon a feeling of pulling against something. Once they're at that point of 8 weeks or so after being healed up appropriately, to be able to take some tension. All right, so there's a lot of problems that can occur just because everything is existing so close together. There's no room for error. So let's say a person, you went through therapy, or for an extensor tendon repair on the back of your hand, and you know what? My wrist hurts now. The whole back of my hand hurts. I had a patient come in a couple of weeks ago, Army soldier actually, and the back of the hand was just really sore. So watch this. If you let your hands come down, naturally the fingers open, because now these extensor tendons are pulled over the back of the wrist, and it's having a pulley effect. It just naturally opens the fingers. If you flop it back, now the pulley effect is over the palmar surface of the wrist and naturally bends the fingers. That's called wrist finger synergy. Now, patients who have some paralysis, and let's say they're not able to actively make a fist because maybe they had a brain injury of some sort, and they're having some paralysis of those muscles that bend the fingers, we will have them use what's called the tenodesis pattern, where they will actively extend, which naturally bends the fingers. So if they want to grab a cup or something, they'll flex like this. The fingers are open, and then they'll extend the wrist, which naturally bends the fingers. Then they could drink like that. So we can take advantage of the mechanics of the wrist and hand. So why do I mention this? When you flop that down, they open. The opposite of that is making a fist and stretching them down. So when I examine that patient and they're normal like that, they're normal like this, okay, now what about, are these excessively tight? And that was what was wrong with them. So, sorry, Mike. I went like this with him, and this side went down good. This side went down about that far. And he said, ow, there's that pain I've been feeling. Okay, I know exactly what's going on. You have extrinsic tightness. You have tightness of the muscles that are extrinsic or outside of the hand. And then I examined them through here. Sure enough, those muscles are very tight, very tender. We did some soft tissue work and lengthened those muscles. And then easy stretch to do at home. Make the fist, grab your fist, bend your wrist until you feel a very slight pull on the back of your hand, back of the wrist. Hold that for 20 seconds. Relax again for 20 seconds. Relax. Do that every 3 hours, which is roughly 4 times per day. And the condition took care of itself. Warm it up in the shower. Do some stretches in the shower. You can use a heating pad on the muscles of the forearm and also over the hand. 10 or 15 minutes, then do a nice light stretch. Heat should only be used 3 times a day so we don't elicit an inflammatory response. And then that took care of the problem. Extrinsic tightness. So that was here. It was really, really tight. Restore the length of the tissue. So every time he did squeeze or move, or he was a mechanic, so he would try to get into these tight spaces, and the back of his hand would hurt a lot just because the tissues were so tight. But, you have to get into a therapist who understands very thoroughly the mechanics of the wrist and hand, and can really, again, tease out the condition. And when I say tease it out, it's sort of, figure it out. When you go to the doctor, you go to the therapist for any condition, it's an investigation. You can think of it as an investigation. When did it start? How did it start? Did you have an injury? Did it since this condition began a couple of months ago? Has it been getting better? Has it been getting worse? Is it still the same? What have you been doing for it at home? Has that helped? And always pause and I ask the patient. I'm good at asking questions, aren't I? And they always say, yes, you are. But we have to really figure it out and get to the bottom of it. I had a guy with one last story. Then that'll wrap up this show. Guy was coming in, cubital tunnel syndrome, numbness and tingling. We talked about that in a previous episode as well. Just wasn't getting better. No matter, he great patient and did everything I said. And this is where you really have to take your time and read the patient's chart and the past medical history. This guy walked so well on 2 artificial legs. I didn't know he had artificial legs. So we were chatting during a session and he said, yeah, I'm gonna buy a ranch house. I just can't handle this going up and down the stairs anymore. I said, really? Why not? He said, well, I got to take off my legs, and then I sit with my back to the stairs, and I go up the stairs on my elbows. I said, oh my goodness. I said, oh boy. I said, yeah, your elbows have been hurting for a long time. I said, you didn't think to mention that earlier. He said, he laughed at himself. He said, not really, because, it's just something I've been doing for 10 years now. I said, oh my goodness. I said, that's, when I was asking all the questions of things, it's something I didn't, who would think to ask that? So we changed the way he goes up the stairs, and he wasn't on his elbows anymore. He got better in 3 or 4 weeks. He was 100%. So anyway, when I say tease it out and figure it out, it's an investigation. We really have to know the person's living the situation. We have to know the past medical history. We have to know, what do they like to do in their spare time? Biking. Weightlifters. If you have the bar and it's resting on your hand and you're in maximal wrist extension, you're resting on your bones, you're resting on the ligaments, but the bar really should be, let's say you're doing bench press. Just let's pick something everybody can picture. So keep that wrist should be sort of straight, maybe back a little bit, but we can't have all the weight pushing down like that. I just saw a patient last week, a woman who was, women tend to be more flexible than men. So they'll get up there and rely on their flexibility and then just let that push down like that. Because I'm asking them, do you do yoga? Do you do this? Do you do that? Well, I lift weights. And boy, it really bothers me when I'm pressing. And then we talked about this, keeping their wrist a little bit straighter, and that usually does the trick. So that's a good ergonomic consideration. All right, that wraps up this show. I want to end with a dedication. I dedicate this podcast to Jesus, who continuously guides me to do right, to do well, and to continuously improve. I'm really happy that I'm able to reach out and help more of my brothers and sisters and on this planet. And I also want to always thank my wonderful wife, who continuously encourages me to follow my dreams. Also, my wonderful family, my teachers in the community who raised me and taught me my values. Also, my professional mentors who were and still are patient with me and continue to answer all of my questions and empower me to help others to my greatest potential. The more I learn, the more I realize how much there is yet to learn. And because of that, learning for me is very humbling. Thank you. Look forward to talking to you again soon.